Coronary artery disease. First of all, we talk about angina. One of the important clues to diagnose angina is history. Now, what is special thing in the history? Classically, patient come to you and he says he has exertional pain chest. That means patient says, doctor, when I walk, I have pain. When I stop, the pain disappears. This is the classical history. And what is the nature of the pain? Patient says, as somebody is squeezing his chest or pressing his chest. He complained of, maybe he may complain of heaviness in the chest. And this is what is called as Levine sign. Well, of course, the most important reason for CAD or coronary artery disease is atherosclerosis, which blocks the coronary artery. But I said, history is the most important to diagnose angina. Why? Because ECG may be normal, echo is usually normal, and cardiac enzyme, they are normal in a case of stable angina. Okay. So that's why Levine sign is the classical thing what we get to see for angina. Now let us learn why this happen, why the patient has exertional pain chest. For that we have to learn the basic concept, basic pathophysiology of angina. Well, angina occurs due to reduced coronary perfusion. Why it is happening in exertion? This is the plaque, this is the coronary artery. This is the myocardium, plaque is there, and at the moment in the resting state, the heart rate is 72 per minute. Now patient start walking, and walking the heart rate increases maybe to 110, 120. When the heart rate was 72, blood was coming like this, demand and supply was matching each other, patient was comfortable. But once the patient start walking, as we know, heart rate increases. Increased heart rate means increased oxygen demand. But there's a fixed obstruction is there, and that lead to reduced coronary perfusion, and this lead to tissue ischemia. That is ischemia of the myocardium. So there is ischemia of the myocardium, and that manifests as pain chest in the form of heaviness or somebody is squeezing the chest. And that's why I said the best way to diagnose angina in a routine OPD is always the history, right? So I hope you are clear about the concept of exertional pain chest. Now same thing, now this is the normal coronary artery, blood is flowing perfectly. Now plaque is there, and now artery's blood supply is less, but in the resting state is normal. But when the patient will start walking, the blood supply cannot be increased because there is a fixed obstruction is there, which lead to tissue ischemia. Now, as I told you, most important cause of coronary artery disease is atherosclerosis. So before we proceed further, let us learn the basic pathology of atherosclerotic plaque formation. We have study classification from stage 1 to stage 6. Up to the stage 1, 2, 3, if things are under capital control, regression is possible. But after that, the regression is not possible. Rather, now they are vulnerable to rupture of the plaque. Now what the plaque is? Well, this normal coronary artery, you can see, and in the early stage, fatty streaks are developed, and point to note it, this streak start formation in childhood, and ultimately WBCs and RBCs, they come and unite this fatty streak. Ultimately in the beginning stage we get a lipid rich plaque which contain WBC, RBC as well as calcium also. Up to this stage, if things are controlled, lipid is controlled, other risk factors are controlled, then it may have some regression. But after that, what happens? Calcification occurs, calcified scar formation occurs, okay, and ultimately it obstruct the coronary artery. Sometime this plaque may rupture and that lead to formation of thrombus. That's the reason why we patient develop acute MI or unstable angina. Remember, up to this only calcified plaque is there. That is the reason of stable angina. Okay, but if this rupture is now a clot may form, that's the reason why MI or unstable angina or so-called acute coronary syndrome occurs. That means if I have to tell you in one line the difference between stable angina and acute coronary syndrome is rupture of the plaque occurs which lead to clot formation is acute coronary syndrome, but if plaque is there, calcified plaque, and it has not ruptured, that's the reason why we have stable angina. I hope things are clear to you. Well, after that we talk about the classification of angina. How we really classify angina? So first of all, we have a typical angina. When we talk about, okay, or atypical or non-anginal pain is there. In typical angina, location of the pain is retrosternal. Or so-called just behind the sternum, and the quality is somebody is putting a lot of heavy pressure on the chest. That's what we could call as Levine sign. And duration of the pain is somewhere between 3 to 15 minutes. This is the typical of angina. Now it is provoked by anything which lead to increased heart rate, like exercise or going uphill or sometime emotional stress. They are the provoking factor. And pain is relieved by classically by rest. This is the typical of angina. Okay, so there are three factors. Location, the typical, location, quality, duration, provoked by and relieved by. Right? Now, this is the pain character. When we talk about atypical angina, when 2 out of 3 features are there, that means pain, provoke or relief. Any 2 are there, then we call as atypical angina. But if patient has pain chest with 0 or only 1 manifestation, then we call as it may most likely it is non-anginal pain is there, right? Now we talk about types of angina, classical angina or stable angina, which we discuss. There is a atheroma deposition is there, and it is excessive exercise which precipitate, and stress and tension precipitate, and the pain is relieved by rest. This we discussed earlier also. Now we have a variant angina or vasospastic angina. It is due to excessive or coronary vasoconstriction. So it is due to coronary, anytime the coronary artery go into spasm. So that's why we call it vasospastic angina. Now, this type of angina is predictable. But this one is unpredictable. What do you mean by predictable? In this we know there is a fixed deposit is there. Well, but the patient will come to you, he says, doctor, when I walk for maybe 500 meters, and after 500 meters I have pain chest. The patient knows by, or patient is going, maybe he's climbing the stair, he says, when I climb 100 stair I get pain. So he knows after 100 climbing the 100 stair I'll have pain. So he has a predictable type of pain. But spasm can occur anytime, any moment. Even spasm may occur at rest also. That's why we never know when the pain will happen. So we call as unpredictable type of pain is there. Well, then we have third, one more entity, so-called unstable angina. This is what I was talking to you, that patient has plaque formation is there. Suddenly the plaque ruptures and that lead to formation of clot or thrombus occur. That's what be the reason, basic problem of unstable angina. So thrombin aggregation, platelet aggregation, and lead to rapid and severe pain, about which I'll be talking to you in the coming few minutes only. Now we have one more entity, so-called microvascular angina, something very interestingly. Here patient come with pain chest. And in the ECG, ECG may be normal, or sometimes there can be non-specific ST T wave changes may be there, but definitely there will not be any ST elevation or Q wave. And when you do coronary angiography is total normal. There is no plaque is there. But why this pain occur? Remember, patient still has angina on a pain chest on exertion. This is due to arterioles. They go into spasm. Myocardial arteriole go into spasm is microvascular angina, and if the coronary artery go into spasm, this is so-called Prinzmetal angina. And this is also known as slow flow phenomena. Patient has pain chest, but with normal angiography is there. Let's talk a little bit more about each one of them. Prinzmetal angina, just I told you, pathogenesis is vasospasm is there. Coronary artery, they go into spasm. This is due to hyperactivity of coronary artery smooth muscles. Okay, and that lead to coronary spasm, as I discussed, so-called vasospastic angina, and it typically occurs in young patients. Usually patients are below 50 years. And something very interestingly, in this, the major risk factor is smoking. Unlike in a routine case of coronary artery disease, what we have been talking, the risk factors are diabetes, hypertension, increased lipid, and of course smoking also. They are the four major risk factors. But in this, smoking is the most important predisposing factor. That means if the patient with Prinzmetal angina comes, the smoking should be stopped with immediate effect. Okay. Now, patient has recurrent chest discomfort, maybe at rest, and during sleep. Point to be noted, in a stable angina, pain occurs on exertion. This is an exception. Patient can have pain at rest also. Why? This is due to vasospasm is there. And spontaneous resolution occurs in less than 15 minutes. The pain disappears because the coronary artery, they dilate within 15 minutes. Then how we really diagnose Prinzmetal angina? You do ambulatory ECG, so-called 24-hour ECG monitoring. What is done and how it is done? In this, patient come to the hospital, and in this we have an ambulatory ECG machine, so-called, the other name is also Holter monitoring. So ECG leads are tied and the machine is strapped on patient body and he's sent home. And patient does all the routine activity. In the next 24 hours, he come back to the hospital. The machine is removed and his data of, the ECG data of 24 hours are analyzed. And suppose the patient come to you in the hospital at 10 a.m. and he come to you in the next day morning 10 a.m. and you take a history. He say, doctor, I had a pain at 7 p.m. last evening. Of course, you are getting a history of pain chest, and at 7, and if you see the data of ECG during that time, you may find some changes are there, and that is the reason that you can correlate. Perhaps this is a case of vasospastic angina. Now, I must tell you what are the usual typical ECG finding in this patient. The ECG finding in this patient are, this is a normal ECG. This is a T wave. In this patient, you tend to get ST segment elevation. This is a classical finding, what we get in vasospastic angina. And of course, when the pain, because the pain lasts only for 10-15 minutes, and after 15 minutes, again the ECG come back to normal. But I'm quite sure you may be thinking, this finding we get in acute MI. Yes, we do get ST elevation in acute MI. But we get this finding in Prinzmetal angina also, which is due to coronary spasm is there. But remember, this is reversible within after 10 to 15 minutes. That means when you are analyzing the data, you are getting this finding at 7 p.m. At 7:15 p.m., when you see the data, it is like this only. So by this, we can interpret that patient has vasospastic angina. And when you do the coronary angiography, usually coronary angiography is maybe normal in this case, or little bit plaque may be there, but not sufficient enough to explain this ST segment elevation. And remember, the most important thing, cardiac enzymes will be normal. N for normal in this patient. If it was a case of acute MI, cardiac enzymes are increased. So you have sufficient point to say that is a case of Prinzmetal angina. Now, how to treat these cases? As far as treatment is concerned, calcium channel blocker are used as a preventive drug. And the best drug is diltiazem. Diltiazem has it's a first generation calcium channel blocker which has main action in coronary artery. But for abortive, we use nitroglycerin. This is if patient has pain chest. To remove that pain chest, as an abortive, we use nitroglycerin, and normally we use sublingual nitroglycerin is used. And something very interestingly, aspirin should be avoided in this patient. Sometimes it can even increase. Why? Because it may increase the ischemia due to increased sensitivity of coronary artery due to prostacyclin synthesis changes. So something very interestingly, and similarly, beta blocker are contraindicated. They should not be given. So aspirin should be avoided in Prinzmetal angina, and even beta blocker are contraindicated because they can precipitate vasospasm. Okay, I hope things are clear to you. Well, so as I was talking to you regarding ECG, you can see this normal, okay, normal ECG or a little bit non-specific ST changes. But when we have to go for Prinzmetal angina, you can see classical ST segment elevation. And they are reverted back after nitroglycerin immediately. Look, all the changes. Remember, in acute MI, nitroglycerin does not lead to reversal of changes immediately. But here we are getting reverse changes immediately within a few minutes only. And of course, additional thing, cardiac enzymes will be normal in these cases. Right? Now we talk about unstable angina. Patient has pain chest, and patient may have one of the three features. One is pain chest may occur at rest or with minimal exertion lasting for more than 10 minutes. It is of recent onset, that is, it is less than 2 weeks. Patient will come, he will say, up to about 15 days back, I was perfectly normal, but now I have got recurrent pain chest, and it is crescendo pattern. Patient says, initially, I used to walk for maybe 1 kilometer, then I used to have pain chest, but now I am getting pain chest, maybe 500 meters. Initially 1 kilometer, now maybe up to 500 meter or maybe 200 meter. So we are getting a crescendo pattern. If any one of the criteria is there, then we think the patient has gone into unstable angina. Okay? So more crescendo pattern also include increased frequency. Patient says, initially I used to have pain chest once in 2 days or once a day. Now I am getting pain 4 or 5 times a day. So crescendo pattern is that what typically we call as unstable angina. Now what are basic pathology? The pathology is, here we have a plaque. We have a plaque with a fibrous cap. This is a fibrous cap, you can see. This is the fibrous cap. And this ruptures, plaque ruptures, and that lead to formation of blood clot. And blood clot has formed, and that has, you can see, it has really obstructed the coronary flow. This is the so-called basic pathophysiology of unstable angina. Well, same thing I can show in a much transsectional areas, normal coronary, okay, normal. And here is the stable angina. Plaque is there, stable. And variant angina, no plaque, but intense vasospasm, which is the so-called Prinzmetal angina. Now we talk about microvascular angina. What I told you, typically patient has pain chest on exertion, and non-specific STT wave changes are seen. Angiography is normal, and abnormal constriction or failure of relaxation of coronary arterioles is a basic pathophysiology. Same thing, you can see this, the arterioles. Arterioles are there, and arteriole are getting compressed or they are getting constricted, so-called microvascular angina, or also told you slow flow phenomena. Nicely depicted in the photograph, that you are understood the pathophysiology of each type of angina. Now, major risk factor for a case of CAD are smoking, diabetes mellitus, hyperlipidemia, and hypertension. Why it is so important to know about? Because when we will be managing the case of CAD, the first thing shall be lifestyle modification. Will tell the patient has to modify his lifestyle. What will tell? Patient has to stop the smoking. Patient should really control his blood sugar by diet, exercise, and medication for diabetes. And he should control his lipid by diet, exercise, and BP should be controlled. So that they are all the part of so-called major risk factor for a case of CAD. In addition, there are certain minor risk factor also. The minor risk factor include positive family history, obesity, type A personality. Type A personality are those people who are always very restless, very aggressive type of people. Sedentary lifestyle. And of course, hyperhomocystinemia, increased level of homocysteine. They are the minor risk factor. Well, in this, we can't change the family history, we can't change. But obesity, we can advise the lifestyle modification. Type A personality, we have to counsel the patient to change his mental temperament. Sedentary lifestyle, again, we ask the patient to go for exercise. And homocysteine, the level are increased, we give folic acid, the treatment which will reduce the homocysteine. And this is what I was talking to you regarding minor risk factor, and it is more in males. 4:1 is the ratio of male-female ratio is there. Now, CAD risk factor score. How we really go for the risk factor? If age, well, patient has come to us, how we really assess the patient has increased risk formation? If age is above 65 years, we give 1 mark. Or 3 or more of CAD risk factor. They include premature family history, diabetes, smoking, hypertension, or cholesterol. Out of these main 5, if we are any 3, we get 1 mark. Known case of CAD, that means if suppose angiography was done previously, if arterial stenosis is more than 50%, we give 1 mark. Or if patient is using aspirin for the low dose for the last 1 week, in the last 1 week, if patient has already started using, we give 1 mark. Severe angina. What do you mean by severe angina? 2 or more than 2 episodes of angina in the last 24 hours, or ST segment deviation of more than 0.5 millimeter, or positive cardiac marker, that is cardiac enzymes are increased, each one of them get 1 mark. So total score comes out to be 7. So the total score is 7. More the risk score, more is likely to have coronary artery disease. Well, I discussed about positive family history of premature coronary artery disease. What do you mean by premature coronary artery disease history? If a patient has come to having suspected angina, we take a family history, and if in the first degree male relative get an MI below 55 years, or a first degree relative, a lady gets CAD below 65 years, then we call it to be premature coronary artery disease. If it is there, it's again a criteria of cardiac risk score. So before I close this chapter of angina basic concept, let's revise the last minute revision point. Angina pectoris history is a very important clue, and what we see is Levine sign. Patient has exertional pain chest in the form of heaviness in pain chest, and type of angina, classical angina, so-called stable angina, variant angina is vasospastic, unstable angina, and microvascular angina, where arteriole are spasm and so-called slow flow phenomena is there. Okay. So in variant angina, coronary spasm occurs. In unstable angina, at rest, recent onset, crescendo pattern. In microvascular is slow flow phenomena, and total risk factor is 0 to 7. Thank you very much for watching this video.